My name is Kayla Axelrod, and
Nahama Fishbane, Passy Ludmere,
and Malcolm Uberfeld.
okay, we hope you enjoy our presentation. So our presentation is regarding adult concussion. So basically, a concussion is a mild traumatic brain injury, which is traumatically induced. It's a physiological disruption of brain function and could be manifested by any one of the following, such as a period of loss of consciousness, a loss of memory for events either before or after the accident, any alteration in mental state at the time of the accident, for example, feeling dazed or disoriented, confused, or any focal neurological deficit or deficits which may or may not be transient. The severity of the injury, however, does not exceed a loss of consciousness for more than 30 minutes. After 30 minutes, an initial GCS, which is a Glasgow Coma scale would be from a 13 to a 15. And post-traumatic amnesia would not last for more than 24 hours. So, just some statistics to orient you regarding a concussion. So in the US, someone suffers from an MTBI or concussion every 21 seconds, which is really significant. The incidence of MTBI is 1.1 to 1.8 million people as of in 2010. Again, incidence is how many new cases were diagnosed per year. And prevalence is the amount of people currently living with this condition, which right now is up to 13.5 million people in the US. Some of the concomitant disorders include irritability, balance issues, loss of coordination, problems walking, seizures, abnormal eye movement, repeated vomiting, unclear slurred speech, and things like that. There is also something called post-concussion syndrome, which is when the symptoms persist after the injury from a few weeks to months, and it's worse in individuals who have had a prior concussion or a head injury, and these symptoms include things like headaches, dizziness, anxiety, sleep disturbances, or cognitive disturbances.
Okay, so common characteristics that come along with a concussion include dizziness, a feeling of being disoriented, vision problems like double vision or blurred vision, headaches, nausea, vomiting, memory problems, general confusion, a sensitivity to light or noise, and in general, like a slow reaction to stimuli.
Okay, so who are we dealing with here? So our case, this we're going to read. We have Buster is a 79-year-old male. I'm sorry. Buster is a 79-year-old male who lives in Maryland. He has 3 children, 5 grandchildren, who are all very involved in his day-to-day life. He's on diuretics for his high blood pressure as well as metformin for his diabetes diagnosis. Buster was a 6th grade teacher in the local public school teaching biology. He retired at age 60 with a pension and enjoys his free time in museums and enjoys mystery novels. His children visit him at least 3 times per week and are constantly checking on their father. On April 3rd, 2018, Buster tripped in his living room and hit his head on the edge of the coffee table, causing him to lose consciousness for an unknown amount of time. Within a half hour, Ben, his eldest son, called, but there was no answer. He called 3 more times before rushing to his dad's house, fearing that something bad had happened. Upon entering, Ben found his father unconscious on the floor and bleeding from a small gash on his head. Rachel, his daughter, had spoken to him last at 11 o'clock before he got to use the facilities. Ben arrived at the house at 11:45, so we know that Ben was unconscious for less than 1 hour. He was rushed to Holy Cross Hospital where he was being treated for his moderate TBI. Buster presents with anterograde amnesia and word retrieval issues. Additionally, he presents with nausea and is disoriented. His son Ben is requesting a cognitive evaluation due to the troubling symptoms which his father is displaying that were not present before the fall. He was in need of physical assistance and was not able to get around effectively. Additionally, assistance was needed as he was forgetting things and was not able to appropriately answer questions. Pragmatics are impacted, resulting in inadequate social communication. So there was a few tests that we felt were appropriate for our patient Buster. So the first thing would be the chart, the WHO Quell Brief, and the PMAI, which is a Portland Mayo Adaptability Inventory, the World Health Organization of Life brief version, and the Craig Handicap Assessment of Reporting Techniques. That's the chart. So we're gonna go through each one of these and why we felt that they would be important for Buster. So the chart assesses 6 domains: physical dependence, cognitive independence, mobility, social integration, and economic self-sufficiency. So after the accident, Buster had difficulty doing things on his own, and definitely required more assistance than he did previously, which we were able to get all this information from his son, who really gave us a clear understanding about his abilities before and after. The who-quote brief is very important for Buster at this point. It consists of 26 items measuring 4 domains of quality of life, which is psychological health, physical health, social relationships, and environment. The PMI-4, the Portland Mayo Adaptability Inventory, is the 3 subscales: Ability Index, Adjustment Index, and Participation Index. And we felt that these tests would really give us a great understanding of how we could best help him in a rehabilitation and to get back to his normal life. And last, the CCABI is just a great checklist to check all the domains and make sure that he is functioning as best of his ability.
Okay, our recommendations for Buster is to receive outpatient speech-language pathology services twice a week for an hour each time. The course of treatment will target areas such as word retrieval, episodic memory, and pragmatic skills. 2 possible goals that we thought would be appropriate for Buster is targeting his episodic memory and to improve his word finding skills. 2 SMART goals that we created were: in order to improve Buster's episodic memory, he will relay a structured 3-sentence narrative independently within the therapy session, 4 out of 5 opportunities. Another one is: in order to improve Buster's word finding skills, Buster will correctly name 4 out of 5 pictures of objects on a picture board independently during a therapy session. So the steps of the treatment for the first goal, which is Buster's episodic memory, will be first we have to get an episodic memory that he will have. So we'll take a caregiver, his caregiver, perhaps a son, one of his sons or his daughter, and we will model an episode that they shared along with Buster, such as an experience that they shared. Then the clinician will model the narrative in 3 sentences and include temporal markers such as first and then. Lastly, we'll then ask Buster to relate to us back independently in an organized fashion. And that would be the steps eventually we were hoping to get to our goal. The next goal would be regarding Buster's word finding skills. First, the clinician will present a picture board with each picture. There's going to be a board with many pictures, and the clinician will name each picture so that Buster has the name of the picture in his mind, and he'll know the name. Next, the clinician will present the pictures on the board and name each picture again, and Buster will repeat it back to him. The third step in this goal is that the clinician will present pictures on a picture board, and Buster will then name the picture independently.
Okay, so in order to educate Buster and his family about a concussion, about the diagnosis, the first thing the therapist will do is just define concussion, so they know what the medical definition is, and the therapist will make sure to use terms that are easy for the family to understand. And in addition, the therapist will let the family know about what symptoms they could expect to see that come along with concussion, and additional alarming symptoms that they should look out for, such as repeated vomiting or a headache that persists and just gets worse, or reoccurring loss of consciousness, in addition to post-concussive syndrome, which could also occur. And the therapist will give the family resources that they could read up on their own, point them out to where they can look for more information on concussion, and obviously the therapist will give the family an opportunity to ask for any questions that weren't clarified. There are 2 resources over here that you can find in Appendix A that the patient and the family can both use for more information on concussion. The end.